We focused mainly on two areas, and I'm going to talk very quickly about the outpatient work that we worked with Lydia as well, that's down in the audience, and then Claire's going to tell you about her project on managing agitation. So what did we do? Well, we first of all engaged with outpatients. We're rather uncomfortable bedfellows are palliative care and outpatients. We realised that we knew nothing about them as a department and they knew very little about us. And I think one of the key findings that we first found when we went down to outpatients is they can be quite a disparate bunch. Lots of redeployed staff there that never really intended to work in outpatients. And actually, us going and paying them a little bit of attention and love, actually, they just blossomed, because actually they said, well, we don't get usually included in things like this. So that was a big win to start with. We listened to patients, carers and staff as well. So one of the things that we first went down there talking about was planning for your future care, which talks a lot about death and dying. And we were told by cancer survivors that had they seen death and dying in a planning booklet, it would frighten them totally. So I went down to a knit and natter group, or stitch and bitch as they like to refer to it as, and actually just showed them what we were intending to do and got their feedback on that, and actually tailored then, and we softened the approach a little bit with a little bit of positivity in there, rather than you're going to die, you'd better make a plan for it. Once we'd refined the materials, we then worked really closely with the outpatient department teams. So from medics to the healthcare assistants within the department, and we did a menu of different opportunities for education. So we looked at advanced care planning, we looked at pain and symptom management, we looked at communication skills with them. And our measurements showed a real increase in their confidence to actually have those discussions, because a lot of the time they would offer a cup of tea but not really know where to take those sorts of conversations. And then we also launched lots of resources that were bespoke to outpatients. So what is it in outpatients that would make things easier for you? And let's design some stuff around that, so be that leaflets or an intranet page or various other bits. Why did we do it? Well, reading around the subject, clinicians want patients to start those conversations. Patients want clinicians to start those conversations. So I thought of it as a bit like the old school disco, with the girls at one side and the boys at the other, and it was just about getting them dancing together, really. And it's actually just acting as that person in the middle to say it's okay to have those conversations. And what were the results? Staff are more confident in having those discussions, more conversations are happening, and there's lots of resources now in place to support that. And sustainability-wise, we've got lots of champions down there in the department, and we're about to go into ophthalmics, which have a footfall of 177,000 fresh advanced care planners coming through the doors every day. So that's our outpatient work.
Is that working?
Yeah.
Yeah, it's working. Yeah. Just need to have it closer to me, don't I think. So often improvement work concentrates on the management of pain, and we wanted to focus on improving patients who are experiencing terminal agitation, a symptom that can be found in up to 90% of patients, but it's something that's not always recognised by the staff who are caring for them on the wards. So we, first off, we created a driver diagram which helped us set out a realistic and measurable aim, and that was looking at all patients who were experiencing terminal agitation to have an effective individualised plan of care by September 2017, and we picked 2 pilot wards. So we were starting small, looking at our interventions and seeing what impact we had. And those 2 wards, we looked at elderly admissions, 2 elderly admission wards, and a stroke unit. The project initially, we were going to go to both those areas, so elderly admissions and stroke, but due to commitment from the end-of-life care team and also staffing issues on the stroke unit, we decided to start in elderly admissions, but then that helped us with our learning on what to do next when we went to stroke. So part of the data collection, we did baseline measurements looking at 5 deaths per month over a 12-month period, looking at was agitation being recognised, assessed, managed, and then we did a ongoing audit during the intervention and then post-intervention to see if there'd been any improvement. From the outset of the intervention on the stroke unit, we had a successful engagement from the stroke clinical educator, which really helped because she helped me when my intervention was working clinically on the ward alongside staff, but also trying to do some interactive ward-based teaching while I was there as well. But her input from the outset really helped with her being able to release staff off the ward so we could have that more formal education. So the ward became familiar with my presence. So when I was on the stroke unit, that was over a 20-week period, and that was, we're going to be going, and I worked alongside 20 members of staff, and also there was 41 staff that received education. It was really important that we engaged with the staff and realised that, it wasn't that they, delivered poor care. It was more about recognising that we were trying to improve that care, and also that I was there to help on the wards. So the audit results from the interventions and then post-interventions, we produced run charts which showed that there had been a significant statistical improvement in the rate of assessment, reassessment and evaluation of terminal agitation, which is on the poster there. And then within the elderly admissions wards, we showed an increased confidence in staff when they were managing agitation. So through collaboration, we have really shown that ward-based role model and weekly data collection has demonstrated an overall improvement in the management of terminal agitation and staff confidence. So, thank you.